That
Right.
is the, I think, Ruchi,
But
take
I'll
it in.
tell you, have people entered? If people haven't done it, I'm going to tell you that I have some lawyers who came in from Amarchand. And one guy came in who was like 29 or 30 years old, and he had a stenosis. His coronaries were really bad.
Mhm.
Imagine at the age of 30, that's what stress is doing to the youngsters. When
Mm.
he came and we had to put a stent that evening, he came back the next morning with four of his friends, and all of them who were like between 27 and 32. And it was incredible that at least one out of four people had some more plaques. So, the thing is that people are not figuring it out, that even young people are starting with disease and they're just leaving it till the age of 50 to discover themselves. So that's
A and B, exercise, gym, this whole paraphernalia, we have to put it in the right, and that will be beautiful, Doc, if you can just give us those little bit of those stories and say, it's never too early and it's never too late. So
totally.
get on to it. And then what I want to do ideally is to have under your watch, have a system where we can keep referring people and they can come get their tests done one by one, whether it's family, whether it's friend, whether it's client, and etc.
Sure.
So I think, Ruchi,
Yes, boss.
madam,
So
you go.
yeah, so I'll just do a little introduction. It's an absolute privilege to have you, doctor, on board, especially in today's day. I think we passed through a rough patch, and I hope it's done with. You'll tell us a little more about that. Those 2 years, I think everybody's trying to figure out what happened. A lot has happened. We're going to share a few things with you today. You're going to share a lot. So thank you for being here. Thank you, boss, for organizing this. I think it was very, very important. Dr. Bhatia, you don't look it, but over 33 decades of experience, 30 years of experience. You look extremely young with 13 years of international experience. And it's a privilege. So I'm just going to leave it at that. We're very, very, very grateful to be here. Boss is going to have a few questions and answers. And you're also sharing the presentation, which is fantastic. So it's all getting recorded, guys. And over to you, boss.
Can we stop sharing for a moment?
Yep.
Greetings, friends.
Right.
Yeah, Doc, can we have you as well on the screen?
Am I not on the screen?
Yeah, now you are. So, greetings, friends. We are privileged to have Dr. Mona Bhatia, who Ruchi just mentioned and gave away her age. And she is that old, unfortunately or fortunately, but we need experience. And her big speciality is something that as a firm, we've seen it ourselves, as a family, I've seen it. And we've been going through this crazy situation of after COVID, and this whole mindset of youngsters now, especially the Gen Z and Gen X, etc., all focused on exercise. Let me give you my thought on it, Doc, for a minute. I've always believed, even though I've been to the pre-Olympic trials in Munich, 72, my younger brother is a gold medalist in the Asian Games in golf. I've always believed exercise killed no one. And I would always say, why take a chance? So I have all the wonderful equipment at home. We have a gym, etc. But I like it's there. It's like Mount Everest. And it's a wonderful feeling to have that. It's there. But I'm seeing more and more, a dear friend of mine, a 40-year-old, very bright youngster. He had COVID, just went cycling, and suddenly left us. One of my own partners passed in his sleep a week, days ago. My cousins, and all kinds of people in the family, etc. And unfortunately, a lot of them had this sudden heart attack. Better. Exercise karke aaye, and they think exercise is the end all and be all of everything. So my request, Doc, is if you can give us a little idiot's guide as to what is the real story as the world changes. We know things are changing regularly, and we don't update ourselves, we'll never get anywhere. So we have a very special guest also, and a number of others who are joining in, and it'll take a few more minutes. But I can see the great and wonderful Dr. Roy and his lovely wife. Dr. Pranoy has just joined us. And thank you, Doc. And we'd be hearing everybody.
Thank you.
And thank you all. This is a very important session and very, very close to my heart. I've done a lot of research, and I must tell you, number of people, whether they were Mayo Clinic, they were Duke, there was Parkway in Singapore, whether it was Medanta and number of others, a lot of the arrows pointed to young Mona doctor. So here she is, Dr. Bhatia. May I, what we'll do, Doc, is I'll ask a few questions just to get the ball rolling. And then we'll open up to your presentation, and thereafter, anybody over here wants to ask any questions, you can put it on the Zoom, or send me a WhatsApp, or send Ruchi a WhatsApp, and we'll be happy to request Doc if there's time. We know she's a very busy lady, and we are grateful as hell and honored to have her with us. Doc, first question. COVID, unknown, known. What are the precautions for children who've been through COVID? My two daughters, at the first one at 9, she got it, the first wave. Then she got it again. My elder daughter, who's now 13, got COVID as well. Touch wood, they're all negative. My wife, and she's slightly older than both of them, she also got it. What are the precautions we should take going forward? They've had COVID. My younger brother, etc., a number of people in the family. So let's start with that, Doc.
Thanks, Rajiv, for a lovely introduction. Very humbling. And thank you, Ruchi, as well. And it's great to have Pranay Roy here. It's totally a privilege. Right. So I think COVID is an unknown story, frankly speaking. And I think we're all learning as we go. And whether it's the CDC from the US or anybody else or ICMR, we're all learning along the way. As far as the cardiac issues of COVID are concerned, now the thing is that whenever we're talking about cardiac diseases, we're talking about two different kinds of diseases. One is the coronary artery disease, where you have the arteries affected. And the second thing is the myocardium, which is the muscle of the heart, which is the part that has to actually do the work and contract and push the blood to the rest of the body. So we have two parts to any kind of cardiac disease. One is, are the arteries fine? So is the pipe bringing the water to the soil? And second, is the soil really viable, ripe for the plant to grow? So, these are two parts. And what happened with COVID was that, unfortunately, COVID got recognized only as a chest condition. People just believe that it's a chest problem. So the entire concentration was on the chest. Nobody was figuring it out, that the fact that it was an inflammatory condition and it was actually affecting every single system of the body, and the cytokine storm that people were talking about, all those things were affecting the heart as well. And the heart has very, very small, tiny vessels that supply the muscle. So that is where the problem came, where people did not take cognizance of the cardiac involvement, and it ended up with causing invasion of the myocardium, which is the heart muscle, and ultimately caused some sort of damage to the heart muscle. So what I do recommend is that if anybody has any palpitations or any cardiac kind of symptoms, they need to get an ECG and follow it up and just verify that their heart has not got involved during the COVID times. Most of the young people have sort of come out of it quite well. So as far as the youngsters are concerned, they're pretty safe. But yes, there have been people post-vaccination, there have been people who've had COVID who have had myocarditis, and it's not something that you can totally neglect, because we're getting people 3 months down the line with evidence of myocarditis, and that we check on the cardiac MRI. So on the cardiac MRI, we see the inflammation, we see the edema of the muscle, and we can tell that this is post-COVID, and then they need to be taking their precautions so that they don't overexert, don't over-exercise like what we've seen. You know, the cardiologists have actually beaten the game as far as coronary artery disease is concerned. They can do bypasses, stents, and everything. But I think what they're really scared of now is the sudden cardiac death. You don't want a patient who comes to your OPD, or, you know, he sees you and the next morning he's dead in the night just because, you know, the guy over-exercised and there was really nothing spectacular happening. So that's.
Thank you, Doc. I just want to ask a lighter question. Why is your profession so complicated? Why can't we use simple words? Microcarditis. ये समझ नहीं आता हमको. We are novices. So if you tell us that, you know, for example, palpitation, people understand, but what the hell is it? Is it you feel some kind of battery?
Ghabrahat.
Acha, koi ghabrahat hoye, so that is a kind of a palpitation. I see. So thoda sa, if you don't mind, there's a, you know, kind of
down to more basics.
I can see a number of wonderful friends of mine on the call, and they would qualify for that nomenclature. So please give us a simple this thing that isme kya ghabrat ho, have it checked.
Yeah.
And then
absolutely.
ECG, how, what, we'll come to the semantics. I'd just like to go into a little bit of detail, peel the onions, and see what should we be doing step by step. I know it'll be a bit longer, but it'll be quicker.
I think step by step, first, just if you think that you're having any kind of symptoms that are related to your heart, you know, whether it's chest pain, pain going to the shoulder, pain going to the jaw, any kind of irregular heartbeat. So you feel that, you know, your heart is pumping too much blood, you know, there's sensations of it. Even if it's difficulty in swallowing, you know, you might want to just go and see a cardiologist and get it verified. And let's not go step by step, because then from there we can be going to multiple steps. I don't want to say you start doing CTs and MRIs, but let's just start with seeing somebody and at least having it evaluated. And let's not just ignore it, okay, oh, this is nothing and it's going to go away. So just be cautious of it, especially since we've gone through a COVID situation where we've had this pandemic, epidemic, and we've had this situation where there are lots of people who've been affected.
Excellent, Doc. That's very useful. And what is the concept of long COVID? I'm going to just take a few questions here and there, and then we can consolidate all of them. What is long COVID?
No, long COVID is just some of the people who continue to have the symptoms for much longer period of time, which could be anywhere from 6 weeks, and it's just going on to almost 6 months. We've still had people who've had, you see, some of them had a bad chest. They ended up with a lot of fibrosis. That, in the sense that initially what happened when we saw Delta, the chest had lots of fluffy shadows because the entire lung was reacting. The lung is supposed to be filled with air, because that's the place where your air exchange happens. You breathe in air, you take out air, you take the oxygen, breathe out the carbon dioxide. So it's supposed to be basically full of little globules of air-filled bodies. Whenever water or anything else substitutes that air, we end up with something that, so the air exchange can't happen. And that's why people were having a difficulty in breathing, their oxygen levels would fall, because all those small globules of air were now getting filled with water, blood, infection, whatever else. So we were seeing all these little globules, but what happened was 15 days down the line, that would land up with something like fibrosis. It's like shreds. It's like fibers inside the lung. Now, those may have a much longer time for it to come back, for it to come back to original. And we still are not sure whether it will 100% come back to original. We're still watching it. So that's what long COVID is, that it just continued over time.
Okay, Doc, that's very kind. Thank you. Is there a special thing with COVID that a lot of people are just getting these heart attacks and gone in minutes, in half an hour? Very good, fit, solid people in terms of exercise, in terms of body fitness, in terms of food, in terms of discipline, all of that, suddenly having a heart attack.
Yeah, because like I told you, that COVID was affecting more than just the lung. It was affecting multiple organs because COVID was affecting the small vessels. And the smallest vessels actually go to the heart. And nobody was thinking about it, that even these small vessels which go to the muscle of the heart, which, they sort of, they bring all the oxygen there, and whenever there is a demand supply, when you're exercising, you need more oxygen. So these vessels should technically be able to become bigger and give more oxygen to the muscle, but they were unable to do so at the time when exercise was being performed. And that is exactly what landed up in the situation where people now had heart attacks happening.
So on a lighter vein, you say villain of the piece is exercise.
Yes, actually, I think what's happened is that we now no longer perform the routine mundane tasks of cleaning the house and doing a walk and things like that. We're all in the gym and we're all doing heavy duty exercise. And then you have the trainers who are taking us from one level to the next, and we're getting more and more aspirational. And of course, when you go to the gym and if you're 50 and somebody else is 24, you watch the 24-year-old and you think you can do that as well, and why not? So I think there's a little bit of an excess that's happening on the exercise front. I mean, how many people ran marathons before, and now everybody seems to be running them? Nobody even knows what's the status of their heart. Yes, most people, especially the corporate sector, is going for annual healthcare checkups, no doubt. But those annual healthcare checkups are what? Usually lipid profile, ECG, TMT, or echo, right? Now, these are the people who are excellent in their exercise regimes. So they are capable of running 4 hours, 2 hours, this speed, incline, everything. So they're, frankly speaking, they're pretty good in their exercise regimes. They are capable of doing those Bruce 1, 2, 3, 4 levels on the stress test. But nobody's tried to look in and see what is actually the status of their heart, what is actually the status of their coronary arteries. Because the muscle, yes, it's been primed to perform, and so it is performing. I've even had, 18-year-olds who go to the gym and have spoiled their heart because they have overdone it. There's people who suddenly take on and say, okay, now I'm going to be on intermittent fasting and I'm going to be doing this kind of exercise. And so much exercise, 4 hours of exercise, protein foods, and all kinds of things are happening. So I think it's really a lifestyle that's, we need to somewhere recognize our bodies and realize that our bodies are not capable of all that and are not meant to be doing that. So there's just no moderation anymore.
Absolutely right, Doc. Absolutely. So we've had, luckily, touch wood, I have not suffered from COVID, but pretty close to that. My whole family, etc., most of it. Should I be doing anything? Certainly, exercise not doing is music to my ears, but
I didn't give you the pass for no exercise. I'm not talking about no exercise. I'm talking about doing the regular exercise.
And in moderation.
Yeah, absolutely. 150 hours every week, moderate exercise, but you don't have to be, running the marathons and running, the kind of stuff that's happening. You're picking up, people are picking up huge weights, and there's a lot of, the gyms have sort of literally mushroomed up.
Out of the way. Now, should there be any tests that people who have had COVID, not had COVID, age group, somewhere where we get an idea of what our heart condition is? Earlier, Doc, before we started, you were mentioning some youngsters because of stress under the age of 30, what they were going through. And a lot of this you're seeing, at least tell me, in your experience, a lot of young people and younger are getting into this so-called after 60 condition.
So I'll tell you, think of it like that. We say that breast cancer, if you have anybody in your household who's had breast cancer, you need to start scanning 10 years earlier than the condition was detected in your family. If there's colonic cancer, we say, okay, almost, every couple of years, you need to have a colonoscopy to check if there's any colonic cancer. So in all the cancers, we are willing to undergo every 3-year checkup and start much earlier. With cardiac conditions, strangely, we've decided that we start talking about it at 45, 50. We've sort of given it up over there. Now, there are some non-modifiable characters, like, in terms of factors like you can't modify your age, your sex, and your family history, right? If you have a family history of coronary artery disease or cardiac problem, you've always had it and you can't change that. But there are certain factors like, your cholesterol, your exercise, your stress levels, your blood pressure, all these are in your control. So we need to at least evaluate that, make sure that we control all that. Now, more than anything else, what happens is that when you go for all these annual healthcare checkups, you tend to just evaluate these aspects. But finally, the holy grail is the coronary artery. Yeah, that is the final word. And what is happening inside the arteries? What is your lifetime burden that you have put on these coronary arteries? Because finally, what's happening is that the fat is going to get stuck on the wall of the artery, and it is going to it's going to slowly start rusting the artery and reducing its lumen. It's going to start narrowing the artery. It's like a pipe. It's like rusting in a pipe. And we say that when 70% of the lumen or the diameter is narrowed, you now need a stent. The point is, we can't really afford in today's day and age to be waiting for that level when 70% happens and we put a stent. The whole point is to start detecting it at the beginning. Now, we as Indians are very genetically prone to coronary artery disease. We have the worst in the world compared to the whites, the Japanese, the Chinese. We're like talking 10, 20 times. It's not only our numbers, but even our risks are high. So we are a very, very genetically prone to cardiovascular disease. And our lifestyles aren't helping anyway. We have the entire perfect recipe for disaster, because we're sitting on sedentary lives. We're sitting, with lack of exercise, our food habits, alcohol, smoking, the works, and we have pollution to add to that. So I think at some point we need to understand that the youth, because the other interesting thing is that the Indians suffer heart attack much earlier than the Westerners. So most MIs happen under the age of 45, which is really early. And that's the time when heart attacks, when they happen at that age, you don't normally come out of it easy. And, you're very prone to a second one after that. So we need to now start looking at, firstly, detecting it much earlier in our youth. We need to be thinking about the youngsters. If there is any family history or if there is any sort of risk factors which may be pertinent to the condition, we need to start looking at their coronaries, check if there's a plaque. And I've seen this, that if somebody comes in and finds that there is a plaque in his coronaries, the chance of that person taking it seriously is way more than somebody just saying, okay, today your lipids are high in your blood test. Okay, somebody says, अच्छा अगली बारी करूंगा, 7 दिन खाना नहीं खाऊंगा, fasting करके फिर से जाऊंगा, नीचे आ जाएगा. Right? Now, the whole point is not what you did to your blood level after 7 days or 15 days of fasting and went back and got it from whichever lab and got a number that looked good. The point is your damage is already done, because what you have done in your lifetime from the age of 2 to 30 is already done. You might have smoked, drunk, done everything in your college days, but that burden is already in your coronary arteries. So who's going to look at those coronary arteries? The only way is to technically look into that. And that's why I'm a big believer that at some point, anybody who has any risk factors or has been through risk factors should at least evaluate their coronaries once and check. Because I feel that if your coronaries are clean, you don't have any plaques, you have no rusting on the wall, then you have a warranty of at least 5 years, if not 7. So just imagine, I mean, I've been to the gym and I felt, oh, I think I'm not feeling good. And I go and lie down in the CT scan and I've said, okay, now my coronaries are perfect. So that's it. 5 years, I'm not going to think about it. It's not my coronaries for sure. If the next time I have a ache and a pain, I'm not going to have to worry. So it's not on the back of your mind. Otherwise, so many times you'll realize you're in the gym, you feel your chest is feeling a little constrained. And then you think, oh my God, I hope I'm not having a heart attack. And there are people in the gym who have it. I have lots of friends who go to the gym and they've actually had a heart attack in the gym and had to go to Medanta and get a stent put. And this is people who've had annual healthcare checkups. Forget the normal population. People like, the presidents of the US had to have triple bypass surgeries. It's not like they were not healthy individuals. They're probably the most, Bush, Clinton, they were all completely healthy individuals, but they've all had stents put suddenly, heart attacks. Why? If we had it so right in just those healthcare checkups, we shouldn't be sitting on that.
Interesting. Doc, this test of checking now, what I've understood is that checking your fiber or checking your coronary conditions, is that non-invasive checking it? Or do you have to check it through a injection or some kind of a surgery?
No. It's totally non-invasive. So effectively what you do is you come in and we just give you an injection of what we call is like a dye. And it just outlines the coronary arteries for us. We can see the margin, we can see the lumen, we can see whether it's narrowed anywhere and what is the cause of narrowing, which is what even the coronary angiogram doesn't do, the invasive one, because the invasive one is just the fluid. They can only see the fluid. They can't see what's happening in the wall, but we can actually see the wall. And
so this is a CT scan?
Yes, pretty much like a CT scan.
You also mentioned the word colonoscopy, just to make it lighter, all this serious stuff. What is the genealogy of the word? Does it come from colonization?
I'm talking about
because
the
it's as painful. I've had it done.
No, I know, but the West has a lot of polyps and cancers of the colon and things. We fortunately have a lot more fiber eaten, whether it's our moolies that we eat or whatever else we eat. But there's the West has so much more polyps, and they are under regular colonoscopies. And if you see the GI lists over there, they're all full of those.
The word है colonoscopy वाला, I shudder because एक बारी मैंने कराया था. ये मैंने सोचा ये वर्ड बनाया कैसे, सोचा कैसे था ये colonoscopy. Then I realized colonization में जो हुआ था उससे बना होगा.
No, colon में scopy हो रही होती है.
Anyway, that is just to make it lighter.
Yeah.
So that's been very useful so far. There's some questions coming in. We'll get there later. Doc, last question from me for now. Quick fix. What are the 3 things we should be doing in terms of pre, post, and continuing? 3 things, simple. Your CT scan, you mentioned, get that done. What age? Any age?
I think I would say if you have no risk factors, but you're leading a life in current days when there's enough stress, then I think at 45 is not a bad time, if not 50 at least, provided you have no risk factors. But if you have anything like diabetes, hypertension, high cholesterol, all those, then I recommend you actually have one CT scan just to verify what is the status. And of course, if you have any symptoms. So just beyond doing only the echoes and the treadmills, because, think of it, the treadmill has a sensitivity of about 40-45%. The people who don't run don't survive that treadmill test and they come up with a false positive. It looks like they were having a heart attack because they've never walked in their lives and they suddenly asked to run on that treadmill, right? The same thing with echo and all. If you do any stress, if the person is used to exercise, he's going to survive it. If he's not used to exercise, they'll get a false positive. So those tests are really not reliable. In fact, the TMT, a lot of people are saying, don't even do it. So I think we've got to figure it out that at some point, I'm not saying just ad infinitum, everybody go and do a CT scan. That would not be correct at all. So I think what's important is to understand what is your family history. Do you have any risk factors? Maybe see a cardiologist. And don't hesitate to get one done, because if nothing else, and if everything comes out normal, at least 5-7 years, you can chill and say, okay, whatever I'm doing is right. It's working. It's not doing me no harm.
Doc, you said 45. After 45, you should get it done.
Yeah.
So Ruchi, that means you have another 20 years to go.
Must.
Thank
Doc,
you.
the floor is yours for your presentation, and then
I think I've actually said most of the things I wanted to say in my presentation. So maybe we can even skip the presentation and go on to the questions. I think I've more or less said what I had to. And everything that I just wanted to show you some numbers, but I think you've pretty much got the impression that just check your coronaries. Don't leave it on just indirect tests, because everything else that you're doing is indirect. The blood sugar goes down if 3 days you don't eat enough. That's fine. It's so easy. And then you say, oh, I'm perfect. Everything's looking good. I didn't have 15 days. You don't have some, anything to do with cholesterol, and you have some low fat food. You might even have your cholesterol numbers looking pretty good. And who knows, you've got a ton load of cholesterol already jumbled on your coronaries. So.
So there were 3 tests I was told, and Doc, you can just tell us that after 45 or 40, especially post-COVID, we should all just most of us should quickly get it done. And what are the symptoms? 1, 2, what are those 3 tests?
I'm not sure I gave you that advice on which 3 tests. What 3 tests are you told?
TMT, something, some CT scan. I can try and get the details.
Okay, so you've got the treadmill, you've got the echo, and you've got the CT scan, right?
So ye तीनों करने चाहिए.
So, which is exactly what I said. Yeah, you could do that. And but that's why I said, go see a cardiologist. If everything is normal, your ECGs are normal, you can maybe take it to the level of 1 TMT. If everything comes out normal, it's fine. But if there is at any point risk factors, you think you have any symptoms, you have, you have a stressful life, you haven't been doing all the right things, and then there's no harm getting one coronary done, a CT scan done. And the echo, again, is really only going to tell you how the heart muscle is moving. It's not going to show you the coronaries. So nothing looks at, finally, it's about the coronaries bringing the blood to the muscle. That is the final call. The only way you can see it is 2 ways. One is non-invasively through a CT scan, and the second is to actually have an angiogram under the cardiologist in the cath lab. That is the only 2-3 ways you can see the coronaries. Everything else is an indirect evidence that, okay, the echo was fine, the heart was moving, but the heart could be moving because you've primed it enough to move. Your TMT may be good because you're used to exercise. So that's what I'm trying to say, is that everything else is an indirect test. Your lipid numbers can look lower or higher depending on if you're on statins. That still doesn't tell you how much is in your coronaries.
So to have these tests done, we can't have it portable. It can't be done in my office, for example. We have to come to a hospital.
Give us some credit, man. Give us some respect.
No, I'm giving. Because of COVID, people get a bit worried, that if you go hospital, jayenge, wahan ye hoga. So if we can, like we did the vaccination in our car park in our building in Delhi. We had it properly sanitized, all of that. And the entire vaccination first and part of the second was done in our car park. People didn't have to go and crowd the hospitals, to help the whole system at that time. Here, is it possible to do it? Maybe set up a couple of conference rooms and just get everybody sheet done.
I think what we could do is we could possibly have a day dedicated and say, okay, we're not bringing in any other patients, or at least, we give you a 4-hour time and say, okay, we'll do your patients over these 4 hours. That kind of a thing can be organized. Or we do, like a whole camp time on any one.
Interesting.
Week.
This is only in Delhi, or we can do it in Mumbai, Bangalore, Hyderabad, our offices.
I'm sure you can do
for
it.
now, the other friends
we could figure it out with Fortis and how we could do it. But effectively what I'm saying is you need to get to a scanner, which is good. You need to have a reader who's good. And so, it's the machine and the man behind the machine.
So you'd be able to oversee this for us in Delhi at least?
We can technically oversee
at least get, apart from yourself, Ruchi, because you're only 20, let's get the others, at least I would say 40, 45, and the stressed out ones, let's get them all on block. And anybody else listening here, you can be in touch with me or Ruchi. We'll help in whichever city you are and make sure that we all get these tests done. It's better to be safe than sorry is my view. Now, if there are any questions, please fire away. Ruchi, there is one. Will you read that out? Let's start with that. And anybody else with questions and other things, let's talk about it.
Sorry. Okay, now. Hi, Doc. This is Karan. Thank you for the session. It was very informative. I just have one specific question. I think Mr. Luthra asked, but I didn't quite get the sort of understanding. Now, for kids who've had COVID once or twice, are any of these tests recommended, and can they go back to normal physical activity of running around and playing, or are there any precautions that one needs to take for children?
I think I think if the kids have gone through it and they're fine, that's perfect, because firstly, the impact of COVID on the kids is much lower. And the other thing is that they're just running around. They're not doing some hardcore exercise like people sort of biking so many kilometers and 20, 30 kilometers. So kids are not doing exactly, heavy duty, vigorous exercise with weightlifting. The problem with the adults is that they've gone, the other extreme. So that's where the problem has come.
Okay, so normal routine for kids.
Yeah, absolutely. Yeah.
The usual school and
Totally. People are going to school, so no issues. Yeah, that's fine.
So I have a question from one of my colleagues, Tavi, and her question is, there she is. Why don't you ask the question, Chavi, since you're there?
Thanks, doctor, for this session. I had a question regarding, cholesterol. So Indians generally have slightly higher cholesterol, maybe because of the food that we eat. But specifically, in my family, there is a history of high cholesterol, and, I'm talking about my husband's side of the family. So, but because of that, and, he's just in his early 30s, but because of that, we've gotten sort of every year we do these tests, right? So as you mentioned, the echo, the TMT, and the ECG, and everything comes out perfect, right? However, the cholesterol is supremely high, it's off the chart sometimes. So of course, the doctor recommends some sort of medicine, but those medicines then, the minute he stops taking it, the cholesterol again shoots up. But still not able to figure out why that's happening, because the tests are coming absolutely clean, right? So is there anything that you would suggest we should do? Is the CT scan, like you mentioned, the CT scan actually tells us exactly what's wrong in the coronaries and all of that. So is that something that you would recommend, or is something else that we should look at and the doctors are haven't told us about?
No, so what happens is sometimes the cholesterol is high, and it may not actually be sticking to the coronaries. Okay. So it would be preferable to get one CT scan done. And if everything looks good, at least for 4-5 years, you don't have to think about it as much as you're worrying right now. And I think that in itself will be a boon. So I think we've got to just figure it out, that what's happening and how much of that cholesterol is actually sitting in the coronaries and how much of it is not.
Got it. Thank you.
What is high cholesterol, doc? Just for the novices on this call.
It's like high sugar, high cholesterol. I mean, these are all little,
But what is the number?
Basically fat.
What should my cholesterol be?
200 is what they say, but every lab has its own number. So I think wherever you're getting it done, it's just correct in the normal range in that lab, because every lab is doing it differently.
Doctor, happy to inform you, doc. I've just got my blood reports, the full story yesterday. I'm 181.
Good.
Dr. Roy
डॉक्टर साहब थोड़ा पंजाबी हूँ, शो ऑफ भी करूँगा.
बिल्कुल करना चाहिए. उसी में
Dr.
जिंदा दिली है.
Sorry, Dr. Pranoy Roy has raised his hand. I guess he has a question. Dr. Roy?
Unmute, doc.
Thank you very much. I really enjoyed listening to you. And I think the most important thing you mentioned, which I would love some more details, is the false negatives and false positives associated with different kinds of tests. And as you say, the indirect ones like TMT and echo, etc., have a lot of false negatives and positives. What are the percentages of all these and of these? What are the 512K? Are this what are the radar checks or what? Not radar. I had that once about 10 years ago. And why not just have a angiogram, because that would give the least false negative. But is there any danger in an angiogram?
Okay.
Sorry, doc, may I just jump in? This is what doc is talking about. Sorry, Dr. Roy is talking about. they used to do this full body scan, 264 ke naya machine aaya tha.
Yeah, that's the one.
I remember him talking to me. He says, I'm waiting my turn. He says, but I'm really worried because my whole life might change once I've gone through this 5-minute, 20-minute thing. And what comes out of it? You remember, Doc? I remember that.
You said you won't be allowed to booze anymore. That's what you said.
I also said that and a few other things. But anyway, please, Doc, sorry, I had to tell that because I remember him telling me my life might change after 5 minutes.
Okay, so you want to look at some data, then I can open a presentation.
Please.
Data
Yeah.
would be great on the false negatives and positives. Yeah.
Not false positive, at least it'll give you some sensitivity and specificity. Can you see my presentation? Am I sharing it?
Yes.
Yeah, Doc.
Yeah, I can see.
So you know that the coronary artery disease is your #1 global killer. So if we are running after cancer, let's forget it. Let's get after this one because it's men and women both alike. And the issue is that the women are not even going to have the symptoms like the men. So unfortunately, they really go as sudden cardiac death. And the huge Indian challenge is that we have 7 to 13% of our urban population sitting on this looming epidemic. And like I told you, that the risk is 3 to 4 times the white Americans, 6 times the Chinese, and 20 times the Japanese. And even if you go to the Americas or the Singapores and go and live over there, it's higher in the immigrants. And it doesn't really matter where you go because you carry your genes with you. And unfortunately, it comes 5 to 10 years earlier than any other communities, and it's much more severe. And under 30, 3 vessels being involved happens in Indians a lot more. Like I told you, under 45 years, 25 to 40% of the acute MIs happen. And then there's the Indian mortality under 30 is 10 times the Chinese mortality from coronary artery disease. So these numbers just tell you exactly where we are. And like I told you, we're sitting on all the wrong lifestyles. But, and the stress, what I wanted to highlight was that stress causes a release of certain hormones, which actually causes the blood to clot, and that is what will stop the arteries. And it also is it's a catch-22 because the moment you have the stress hormones coming up and playing up, you have increased blood pressure, you have binging, food, alcohol, it raises your cholesterol, it sort of backfires on everything else. The diabetes gets worse, you causes obesity, people may take to smoking. So stress basically just triggers every other risk factor. And that is why our index of suspicion needs to be very strong amongst the young. And really what I was trying to find was the mantra. And up till now, what people were calculating was based on age. So that really doesn't help because effectively, if we only look at age as the risk assessment tool, then you need to treat every single man who's 60 years old and don't treat any of the women till they reach 60, because the way that Framingham risk score has been designed, it's all cool for the women. So what we do is that this is the simple test. You just go in, and this is even without any injection. We just look at if there is calcium in the coronaries. If there is calcium in the coronaries, that means that these coronaries are not normal, because it's not normal to have calcium even at old age. It only happens in an atherosclerotic artery. And here you have to give no contrast, no IV line, no patient preparation. You just come lie down. It's a pretty low radiation test, very reliable. And it gives you an idea of what's happening in the coronaries. But so here you can see that this is where the coronaries, you can see the calcium that deposits. And this is effectively evidence that there is subclinical disease and it may progress to an overt coronary artery disease. And these calcifications start like these punctate small little dots and then later become much more and become more dense, right? So here is against the exercise treadmill, the calcium score is a better risk assessment tool. And there's lots of data on if you have a calcium score of 0, then if you compare it to the stress ECG, the stress echo, and the stress MPH with nuclear scan, the sensitivity of these is 68, 76, 88, but for the calcium score of 0, it's 98. But what is important to understand is that the calcium score doesn't work in the young because calcium doesn't deposit so fast. But once you have somebody who's older and you're looking at calcium, what we're really looking at is your calcium in a percentile score higher than what it should be at your age? So if you have a certain set of normals and you say, okay, this is your percentiles, then you don't want at 40 years your calcium score looking like a 60-year-old, because that means you're actually accumulating it much faster And we need to then slow it down, and we need to take very, very strong steps. So what you were talking about, the 512 and the 256 slice scanners, this is what we see. We see the coronary, we see the entire coronary artery. These are the 3 coronary arteries. We're going to be looking at their margins, so there's nothing sticking and depositing there. We're looking at the lumen, and it should be basically a clean pipe. It gives off its branches and it sort of supplies the myocardium. So this is what we're looking at when we're looking at the coronaries. And the challenge is that when a person walks in, his symptoms could be anything. He could have chest pain from just about anything. It could be even a cough, and you can't make it coronary. His clinical workup, his markers, his blood tests, his ECG, they're all extremely, they have their limitations. They are not reliable. And the spectrum of disease could be, you could be normal, you need to just go back home and rest and chill it out. Or you could actually need to be in the cath lab that afternoon. So the whole spectrum of disease is so vast, and people's the way they react and the way they actually come up is so different, that you really need something that is looking at the coronaries. And that's where the CTA helps. It gives us the entire coronary tree. And here I'm just going to show you that this is a true angio, and this is the CT angio. And you can see how this and this is almost identical. So the level of concordance of the 2 studies is excellent. And the fact that this is non-invasive and this is actually invasive. So if I had to be looking at anything, I wouldn't go into it. The other thing is that when you're looking at the sensitivity, again, we're looking at the treadmill having a sensitivity of 68. If you're looking for narrowing in the coronary arteries, these are your sensitivities. So between the treadmill, the echo, the dobutamine echo, the nuclear study, it's CT which goes to the level of 95%. So that just shows you how the CT is way more sensitive than all the other investigations. But what's really important is that you don't want to get to the point of stenosis. You want to look at that plaque which is just started, because that's the fatty plaque. That's the fat that can just be very friable. It will break off and go and stop some other small artery. So you're looking for that plaque that could ultimately rupture, what's called a vulnerable plaque. So when you look at the CT, you can see the lumen, you can see the artery, the flow and the contrast, but at the same time, you can see that the wall has now got deposited with this fat. And this is what is the dangerous part. This narrowing may not be to the level of 70%, it could be only 20%. But the moment you have this fat, which is sitting over here, that's what's tricky. So this is the coronary angiogram, the true angiogram. And this is the CT angiogram. And now you can see that how I can see the wall, whereas the angiogram can't see the wall right there. So to Pranoy, to your question, this is what is the advantage. So if somebody who did not have to have a stent put or a bypass at that time, I would not recommend them to go to a invasive angio, because an invasive angio has its risk. It's an invasive procedure. And what you were looking for is an early pickup. What you're looking for is this plaque, because this is what, once someone sees that his coronary is sitting with a plaque, he is, for the hell in him, going to start improving his lifestyle, because he knows he's sitting with this and now it needs to be handled with care. So I think this tells you way more that your coronary is already impacted, more than any blood test could ring a bell. So this really rings the bell.
Very, very clear. Thank you. Very clear.
Great question, Doc. Sorry, Ruchi.
Boss, there's advocate Rishabh Khandelwal who's raising his hand.
Ma'am, thanks for the insightful session. I just had one query, that my father has a Parkinson disease and he had just contracted COVID. So do you think in the coming future, he has turned negative. So in the coming future, has it elevated the risk of a heart attack or increased chances of an attack? And what are the precautions do you suggest?
No, I don't think, let's not make every COVID look like we're having a heart attack. So it's not, I don't want to take this as your take home message at all. I think, like I said, you need to evaluate the heart if there's any symptoms that are related to the heart. Otherwise, we're just hoping it was a mild chest infection and it went away. But if there is still a long story where there's difficulty in breathing, oxygen levels are low, prolonged time, then yes, the heart could have also been impacted because it was a serious COVID. Because when it's serious COVID, the chance of the heart also being infected is much more. But if it's just mild COVID, which just came and went away in a couple of days, and for the children and all that are having, I don't think I want to make this into something where everybody starts running to a CT scan or an MRI.
Okay. Thank you, ma'am. Thank you so much.
Welcome.
Bobby, sir.
Yeah, hi, Doc. Thank you so much for a very nice session. I think it's been very informative. I just have one question, and I think got a part answer to that. For somebody who already has hypertension and diabetes, and his kidney functions are impaired to the extent of some creatinine levels going up, would you advise a contrast CT scan, CT angio, or would you advise a no contrast CT scan? And
So the point is that it depends on what is the level of the creat.
Right.
Okay. So if when we're looking at the creat, we look at an eGFR. So you get the GFR done. And if it is under 30, there's a no-go, we can't give contrast. 30 to 60, you're still at a high risk, and above 60, it's fine. So I think what you have to look at is the eGFR number. And depending on that, one takes a call. What is the risk? What is the benefit? And then looks at it. Because obviously we're not going to do tests that are risky to the patient, but you have to look at the cost benefit analysis.
Yeah, and what is eGFR? I'm sorry for asking this. I mean,
the eGFR is they take the creatinine number and they divide it by the BSA. It's sort of a formula that comes, put into Google, it gives you an eGFR number. So if your creat is like, again, every lab has its own number, varies from 0.8 all the way to, some people have normals up till 0.9, some people have normals up till 1.1. So whatever the number that you have, you just take the correct number and then plug it in. And usually the lab would have given it to you. Wherever you've got your lab results, you probably have an eGFR written at the bottom.
Okay, thank you so much.
Doc, very quickly, just look at Bobby's face. Just as a basic thing, do you think he's in reasonable health?
In perfect health.
Now, he has suffered me for 30 years. That's credit to me.
Let's put it this way, looking forward to another 30.
Fantastic. I'm sure they're going strong.
Thank you so much, Doc. Thanks a ton.
No, very useful, very good pointers. And I think a lot of us will go home peacefully, but we'll set this scheme up. At least my view is, जिनका कराना चाहिए आपसे एक बारी अलग से बात कर लेंगे, and let's just get that some criteria, some questionnaire. Maybe we can ask you palpitation or this condition, that feeling or that. Whoever has it in the firm, we can start with that, or amongst our friends like Mr. Khandelwal, etc. We can get this whole camp organized then. Sure. It'll be useful. It'll give me, with this stress world, and the way the world is changing, and the other confusions, of course, we older people were told yellow nahi khana ande ka. Ab sara Time magazine cover pe aa gaya yellow khao. Kabhi kuch butter nahi khana, kehte hain aap butter hi khao. So these confusions, I want to make it simpler if I can, with your help. What should we be doing in our daily life? I know it's easier said than done, but क्या करना चाहिए? But ये test तो मेरे हिसाब से जो मेरी जितना brain है, करा लेना चाहिए सबको. क्योंकि इतने सारे लोग मेरे around अपने personal जानने वाले, I mean, of course, from Bollywood to others, and all heavy-hitting, fit people, they're just dropping like flies.
Yeah.
So and we as lawyers also, and as doctors you have such a stressful life. The only difference is we charge for every minute, and we get paid by the hour, which is not you.
If I don't pick up the phone at 12 in the night, I'll probably have somebody saying she didn't pick up the phone. So I was just, it's interesting. And for the lawyers, they say everything has to be billable, right?
Not only billable. See, we have a fatal flaw in us. It's a manufacturing defect, and the warranty period is over. We read only when we are paid.
Lucky you. And I think the best thing about the lawyers is that the community's kept it strong enough that nobody's had the guts to walk in. I think
we are a noble profession, Doc. We do a lot of human service as well. And I can speak on behalf of all my entire office and my entire family. That's the way we are. And we are also working very closely with various doctors at various levels for various issues. We are also, for example, this current Tokyo Olympics, we are giving free legal advice to all the gold medal winners, whether it's para or otherwise. We are right now working on a whole project to make the armed forces tax-free for life,
Wow.
pension or otherwise. And a lot of such initiatives we've been doing. We will continue to do those, and those are all pro bono. We don't get paid anything.
No, I'm sure.
So the rations that became tax-free, yours truly fought that case and got it done tax-free way back in '83.
Brilliant. No, definitely.
So,
I think it's a profession that has its, it has a noble cause to it. And I think law also has changed so much, and you've now got so many diversifications, divisions and verticals, and it's
see, I always stay with what I say. I said, "मैं पंजाबी हूँ, show off करूँगा." मैंने कर दिया. Now I believe there's another question, Ruchi.
Yes, Ashima Ori has raised her hand.
Madam Ori.
Hi, sir. Thank you so much. Hi, doctor.
How are you?
Hi.
I'm well, sir. Thank you so much. A great session, ma'am. Just wanted to ask a question. Personally, I'm under 35 and was recently diagnosed with unstable angina for my high resting rate. Now, I do want to get some follow-up tests done, but I was sent home with a Ciplar and an Alprax for anti-anxiety. In this regard, would you recommend me to get the CT?
Yes, I would.
All right. All right. Thank you so much.
Check your family history and all, because I'll tell you, it's interesting how family history is also, your genes come from two parents, right? And I've had people who come to me and their siblings, and one may have very severe coronary artery disease and the other one is perfectly normal because, they just got that genetic pool from different parents. So it's pretty different. So yeah, definitely. And please verify if you have any other risk factors in family history, which could be the cause.
So there's one of my angels, Kumud, who has a question. She protects me beautifully, even from her son, who's my lawyer. And her question is this whole intermittent fasting. In fact, Kumud, why don't you put your video on and ask the question? You're there. I can see it. She's a great singer as well.
She's raised her hand.
Kumud, unmute. There she is.
Yeah, hi, doctor. Thank you so much. It was such a nice session. And just have a question, because you mentioned intermittent fasting amongst the youngsters. It has become more of a fad and a trend. I don't know if it is counseled or not counseled dietically, but they think it is a feasting and a fasting, and a fasting and a feasting. What are the shockers to the heart in this case?
I don't think there's anything proven as far as intermittent fasting is concerned for the heart. But I think for people who want to lose weight, it seems to be working. And I think that's what people are technically using it for. And so I don't think there's like too many diets out there, and we really don't know how each of them is impacting. So nothing is proven as far as the heart is concerned with intermittent fasting.
So later, when they come into their mid-years and all, this is not going to cause any jeopardy to the heart.
Hopefully not. Hopefully they're not going to continue this for the rest of their lives.
Okay. All right. This was just my mother. As a mother, I'm worried about children around me, going on these diets. Thank you so much. Thank you so much, doctor. Thank you.
Keep well, Kumud, and beat your son up from my side.
I will. You beat him up.
But thank you very much, Doc. Any more questions? Because we've already taken a whole hour and more of the great Doc, and very kindly she's been to us with full attention. Any other questions? Or we should just thank Doc. Do you have any questions for us?
No, I think you're a great field, and I'm absolutely loving being in this lion's den of lawyers. And I can't
not paying any money.
An hour with the Rajiv Luthra without paying money. I know, absolutely, that's true. An hour, totally.
But Doc, really, from the bottom of our socks, each and every one who heard you, really bottom of our socks, we want to thank you. We wish you well and God bless you. And we will then follow up with you and set everybody on the right track and all be nice and healthy and everybody be safe and happy.
Thank you so much. Thank you,
All
Rajiv.
family to talk, including your brother in Singapore. Love to everybody and God bless, and inshallah we'll meet soon.
Totally. Thank you so much.
Thank
for
you.
having
Thank
me.
you very, very much. Thank you.
So much. Thank you. Totally a pleasure.
Privilege, ma'am. Thank you so much.
Thank you very much.
Thanks.
Bye-bye.
Bye. Bye.
Thank you.
Thanks.